Alright, so I've had permission to use this stuffed animal for this demonstration. I've already read the McKernan's text and watched the instructional video. Basically, we believe that he has a fracture. I'm going to ask my restrainer to hold him while I put a muzzle on him. And then we're going to put him on the towel. We're going to use this towel as a modified stretcher. Bring him up here. And then I'm going to put a modified splint on him. So I have the splint. I'm going to ask the holder to hold the pet so he doesn't bite me. I have the splint on, and then I'm going to put the cast padding on. And I'm going to start from the bottom and work my way up. And this is basically just to stabilize it until we can do a more thorough evaluation. So there is his modified splint. Alright, I have permission to use this stuffed animal for my demonstration. I've watched the instructional video and I've read the McKernan's text. This pet has a bleeding wound from his leg. First thing that we want to do is put a muzzle on, both for his safety and mainly ours. So I'm going to ask my restrainer to hold so I can get the muzzle on. And we want to do that as gently as possible without causing unnecessary stress. So the wound is bleeding right here, as you can see by the red. So we're going to put pressure on that wound for about 3 minutes or so. And if it doesn't occlude, after 3 minutes we check it and it's still bleeding, then we'll actually want to put on a pressure wrap. So we're going to use vet wrap to hold that area and apply pressure. If at this point it's still bleeding through the bandage, then we want to place a tourniquet. And basically you're just going to put the tourniquet above the wound and tighten it. And then you don't want to leave the tourniquet on too long because obviously you're restricting the blood flow to the limb. So about every 15 to 20 minutes you want to take the tourniquet off, let the blood flow to the leg. Hopefully it's clotted by then. If not, reapply it. But leave the tourniquet off for about 10 seconds every 15 to 20 minutes just to make sure that the leg itself doesn't lose blood flow. So yeah, that is applying pressure to a bleeding wound.
Go.
Alright, so I'm going to be demonstrating how to handle patients that have either a chemical or a severe burn. I've already watched the instructional video and I have read the text. Basically, if you have a patient that comes in with a chemical burn, then you are going to want to flush the area as much as possible, because if there is any chemical residue still on the skin, you want to get that off as fast as possible. So I have a bowl of water here, and then we normally use a bulb syringe. And so I'm just going to continually flush that area. If it's a large area and you have access to a wet table, sometimes it is beneficial to just put the pet on the wet table and use the spray hose, and you just really want to try and get whatever residue, if there is any, off of that area. On the flip side, if you have a patient come in that has a severe burn, you are going to want to put a cold compress on the area. We have these sandbag type material that go in the freezer, so they hold on to they stay cold for a long time. And so yeah, severe burn, you're going to want to use ice, cool that area down. If it's a chemical burn, then you're going to want to flush it and get all of the residue off. I've already had permission to use this mannequin for my demonstrations. And that was a demonstration on how to handle a patient that has either a chemical or severe burn. Alright, so our next demonstration is how to deal with a choking patient. I've already watched the instructional video and read the McKernan's text. Basically, you want to look and see what our gums look like. If our gums are a bluish color, that means that we're cyanotic and we're not getting enough oxygen to the tissue. And so we're gonna open the mouth and we're gonna check inside to see if we can see an obvious obstruction. Again, being very, very careful to where we don't get bit and the patient doesn't get hurt. If we can't see an obvious obstruction or get it out, then we're gonna go ahead and move to the Heimlich maneuver. And basically with that, you want to go right behind where the ribs stop, and you're going to squeeze the abdomen to cause a gust of wind to hopefully push whatever that is in the trachea out. So, and you can even pick the patient up because you want it to be a pretty strong gust of wind to be able to push whatever that is. If that doesn't work, then another approach is to turn the patient on its side, put your hand palm down in that same area right after where the ribs stop, and you're going to apply pressure trying to create that gust of wind to push the obstruction out. And hopefully between all of those scenarios, you're able to get the obstruction. If not, hopefully the vet's here by now. Yeah. Alright, I am going to be demonstrating on how to properly take care of a patient if they present with a heat stroke. I've already watched the instructional video and read the McKernan's text. We've already taken a temperature. His temp was 105, which is typical of a heat stroke. Basically, our first step is to take some wet towels that have been cooled off with cool water, and we just want to place that around the head and neck area. And basically this is just trying to bring the patient's temperature down. You can also use, if you're near a wet table, you can take the wet table hose, spray the abdomen, feet, anything to help bring that patient's temperature down, because the longer that the patient stays at a high temperature, the more damage it can do. After, you're continually going to be taking temperatures to be sure that it is coming down, and at this point we would already have been in touch with a veterinarian, and he would tell us whether they wanted us to put in an IV catheter and maybe give some cool fluids. So yeah, that is the procedure on how to take care of a patient with heat stroke. Okay, so this patient we believe came in with shock, and basically we just are going to check all of our vitals. We want to look at the mucous membrane, see what color it is, also get a capillary refill time just to make sure that blood is flowing properly like it should. We also want to get a femoral pulse to make sure that we have a full femoral pulse. You're going to want to get a heart rate, and while you're getting a heart rate, you're going to check for a pulse deficit, which means you basically want to make sure that for every heartbeat you can feel that beat in the pulse and there's not a pulse deficit there. You want to make sure that you listen to both sides of the heart, and a lot of times I'll just go ahead and listen to the lungs too, since we're here. You also want to get a temperature. A temperature can let you know whether the patient is compensating or decompensating. A lot of times our clinic is okay if we have a patient that comes in and is shocked to go ahead and put an IV catheter in and start a slow drip of fluids, and to stabilize us until the veterinarian gets here. So yeah, I've watched the instructional video and I've read the McKernan's text, and I have permission to use this mannequin for this demonstration. shock. And basically, we just are going to check all of our vitals. We want to look at the mucous membrane, see what color it is. Also get a capillary refill time just to make sure that blood is flowing properly like it should. We also want to get a femoral pulse to make sure that we have a full femoral pulse. You're going to want to get a heart rate, and while you're getting a heart rate, you're going to check for a pulse deficit, which means you basically want to make sure that for every heartbeat you can feel that beat in the pulse and there's not a pulse deficit there. You want to make sure that you listen to both sides of the heart, and a lot of times I'll just go ahead and listen to the lungs too, since we're here. You also want to get a temperature. A temperature can let you know whether the patient is compensating or decompensating. A lot of times our clinic is okay if we have a patient that comes in is shocked to go ahead and put an IV catheter in and start a slow drip of fluids and to stabilize us until the veterinarian gets here. So yeah, that I've watched the instructional video and I've read the McKernan's text, and I had permission to use this mannequin for this demonstration.
Okay. What's called myself?
We're in Manual Clinic on Hillcrest. Hey. Okay. Yeah, we're open 24 hours. We have emergency hours as well. Do you know how much chocolate we got into? Okay, so about 18 ounces or so. And do you know, is it milk chocolate, dark chocolate? Okay. And do you know about how long ago that happened? You said you said she got into it last night? Okay. What kind of, you said it's a dog, right? And what kind of dog is she? About how old? About how old is she? And it's a girl. About how much does she weigh? You've been in... Okay. And have you been into our clinic before? What's your last name? What's your first name? Alright, and you said that she's acting restless. Is she showing any like vomit or diarrhea or anything like that? Okay, I think we are past the time period where we could make her vomit. I would highly suggest bringing her in. Our office visit right now is
67.
$67, and we have a doctor in the clinic until midnight. Let me see if he has any. What time do you think you could be here? Okay, I'm gonna go ahead and put you on his schedule just so that they'll know that you're on your way. And just in case, what is the best number to reach you at? Okay. All right, well, we will see you said in about 30 minutes or so? Okay, that sounds great. Whenever you get here, you're just gonna come to the side door and ring the doorbell. Our front door is locked right now. So you'll come to the side door and ring the doorbell, okay? That sounds great, okay? We'll see you in a few minutes. All right, bye-bye. Okay, so that actually was a toxicity call on accident. That was not planned at all. But he was saying that his dog got into a bag of chocolate, 18 ounces of semi-sweet chocolate chips. He believed that it happened last night, so we were past the period of where you can induce vomit and it be successful. That's why I didn't even go and talk to the doctor and ask about that, because we just know that it's been too far along. If we do want to get them to induce vomit per the veterinarian, you're going to use about 1 teaspoon per 5 pounds. And you can also repeat that dose, but you don't want to go over 3 tablespoons altogether. I went through and asked the species, breed, age, sex, weight, symptoms, what we got into, when it happened, how much of the toxin we got into. Ultimately, you always want the client to come into the clinic, just because they may not necessarily be very accurate in telling you what's going on. If the dog throws anything up in particular, like some type of foreign body or chew toy or string or anything like that, you want to get them to bring that material in. If it's some type of rat poison, you definitely want them to vomit if it's okay with the veterinarian, and they for sure need to come on in because that's a delayed toxicity. If they have ingested any type of bleach or drain cleaner or chemical or something to that nature, it can actually cause more damage if you induce vomiting. It can burn the esophagus, so we don't want to induce vomit for situations like that. This is actually a client of ours, so I went ahead and made an appointment for him. And then one thing that's important for our clinic is to get a callback number, because sometimes we'll have a client that says they'll be here in 30 minutes and they don't come in, when actuality they don't realize that our front door is locked after hours. So they need to come to the side door and ring the doorbell. We've had people before that they think we're closed. So it's really good to just have that contact number so you can follow up with the patient and see how everything's going. So, but yeah, that was a discussion with a client on possible toxicity. I have already read the instruction manual on the instruction pamphlet on that protocol. And just for good measure, I also watched the instructional videos that were posted. I just wanted to add one thing to that video. If the client does not want to come in, at the very least, they need to call poison control and double check and reassure them that it's whatever the toxin they got into is poisonous or not poisonous, just to cover all the bases. So yeah, that was a phone conversation with a possible toxicity case. so I'm going to be doing a demonstration on how to care for a patient that's having a seizure. I've watched the instructional video and read the McKernan's text. Basically, with a patient that's having a seizure, your main priority is just to keep them from hurting themselves. If they're having violent convulsions or paddling or anything like that, they can tend to bang their arms and head and everything else on hard surfaces. So it's important to have them move them to a padded surface if they're not already. It's also important to make sure that you don't have a lot of loud noises. Sometimes you can dim the lights. Anything that's going to have external stimulus, it can increase the duration of the seizure, and just you want to create a tranquil environment for the patient that's having the seizure. It's important to make sure that you kind of keep up with the time so you know how long the seizures lasted, and if they have them back to back, you keep up with how many they've had. As soon as we have a seizure patient, we immediately get them to a safe environment where they're not going to hurt themselves, and then we'll call a doctor or page for a doctor to come to treatment so that they can give them some type of anti-seizure medication to hopefully bring them out of the seizure if they don't come out of it themselves. You can put a towel up underneath their head to kind of raise their head up a little bit. Again, make sure that it's well padded. Basically, you just want to protect the pet from hurting itself during the convulsions. So that is taking care of the patient under while they're having an active seizure.